The broadcast is now starting. All attendees are in listen-only mode.
All right, good evening, everyone. We'd like to welcome you to our Colic Webinar. My name is Angie DePoit, and I'm the chairperson for the Fauna Education and Health Committee. And so before we start our presentation tonight, there's just a few things that I need to go over with you guys about the controls. So on the right-hand side of your screen, there's a toolbar. And you may find this distracting, so you can go ahead and minimize that toolbar by simply clicking on the orange arrow there. This should allow you the opportunity to view the entire presentation if you wish. During the webinar, the audience will all be placed in listen-only mode throughout the presentation. If you wish to ask a question, and you can do it one of two ways. You can first simply type your question in the question box of the toolbar, So if you look down there, you should be able to see that question box where it says questions. And so you can just type it in there, and I, as the moderator, will be able to see that question. And when we get to a point where we can stop and view those and have a discussion, I can read that question for you if you wish. If you would like to ask the question in person, you can also raise your hand. So if you look there on the screen and you see that little hand icon, if you select it, this will let me know that you have your hand raised and that you have a question. And so again, we'll stop periodically as time allows during the presentation, and I will unmute you if you have your hand raised, and then you can ask your own question if you like. Chances are we're probably not going to get through everyone's questions today. This is a large presentation with a lot of information. So if we don't get to your question, you can always send it to the Fauna office after the webinar, and that's fauna@fauna.com. And we'll be happy to respond to that in a timely manner. So once again, I'd like to thank everyone for attending the webinar. It is being recorded, so if you have to step away, you will be able to find it in the Fauna library and the Fauna YouTube station. At this time, I would like to introduce our speaker, Dr. Samuel Hurcombe. Dr. Hurcombe is an emergency clinician, surgeon, and internal medicine specialist and clinical associate professor at Cornell University College of Veterinary Medicine. Dr. Hurcombe has won numerous awards for clinical research, service, and teaching, and of course, one of his specific areas of interest is medical and surgical gastrointestinal disease, i.e. colic. And I happened to just be speaking to him before this, and he's actually had a couple colic cases today and actually done a surgery just before this. So he's very experienced, and we're very thrilled to have him. Also, I think with us we have Dr. Fox from the Fenway Foundation for Friesian Horses. She is obviously, to most of us, she's an authority of sorts on the Friesian horse throughout the world. She's also a health advisor to the Fauna Health and Education Committee. So if we do happen to get into a discussion, which is very breed specific, Dr. Fox was kind enough to agree to assist with those questions if needed. So with that, I believe that we are ready to proceed. So I am going to now turn the controls over to Dr. Hurcombe, and then we'll get started. So just give us a second here. Okay, let's see. Okay, Dr. Hurcombe.
All right, thanks, Angie, and thank you everyone for attending this webinar. It's going to be a little bit of a whirlwind of information. To do colic justice in the space of an hour is a really tall order. So where I could find the proof of the pudding in the literature, I've included that information specific to the Friesian breed, but much of this presentation, is general to all horses with colic, but with particular reference to Friesians where appropriate. So, without further ado, so this just a bit of background about me, just so you know who you're talking to. I am Australian. I'm from a little city down here called Adelaide. Went to vet school in Perth and did my internship in Sydney over here. Contrary to a lot of people think, I'm not from England. I have a slightly British-sounding Australian accent, but I'm not British. I'm from Adelaide, a city of festivals and churches, the Adelaide Crows, which is Australian rules football, which is real football, not like American football with pads and helmets. Beautiful beaches, not so nice creatures in the waters, land of the great white shark. This is our state, food, which is a meat pie floater, and I challenge you to enjoy it because it's phenomenal. I went to vet school at Murdoch University in Perth in Western Australia. That's where I did my veterinary school. I then went to Sydney at Randwick Equine Centre, where it was predominantly thoroughbred race horses. It was a referral centre that did medicine, surgery, and emergency. I then went to beautiful Columbus, Ohio, where some of you may be in the area are tuning in tonight. And I was there for actually 9 years. I did my internal medicine residency there and became board edited by the American College of Veterinary Internal Medicine. I did a master's degree in clinical endocrinology, and then I stayed on because I was a glutton for punishment for an emergency and critical care fellowship, where it was predominantly me being on call 24/7 for about 2 years straight, cutting every single colic that came into the hospital, dealing with every single, especially equine emergency. So I really became a Buckeye, and I stayed on there as a faculty member for 4 years or so after all of that. And then I got wooed over here to New York, where I'm the head of internal medicine and emergency and critical care. And this is where I've been since 2014. So that's basically where I'm, who I am. So first of all, this is probably redundant information for most of you, but what is colic? It is a general term for abdominal pain, and it has a myriad of causes. I know it's one of those words that everybody kind of, starts to clench and get a little, tachycardic, and their heart starts to race. But it most often refers to gastrointestinal tract problems. But we have to remember, and I've certainly had my fair share of horses where the abdominal pain or the signs of abdominal pain was not gastrointestinal in nature. And I've got a really good example of a Frisian with a pretty wacky non-GI cause of colic for you later in the presentation. But anything in the abdomen can cause potentially those signs of colic. There are some non-abdominal pain lookalikes, and so those are, those are things like a horse that might tie up really badly, certainly being of draft lineage, PSSM or polysaccharide storage myopathy could, in an acute attack, manifest and look like colic. Laminitis can affect any horse, and especially if, say, you had Potomac horse fever, where they tend to get laminitis in multiple feet. They can look really painful and be wanting to lie down, and so you just have to remember that colic there can be some imposters out there as well. Okay. So part of colic, and this is probably what scares people the most, is if your horse has to go to colic surgery, because by and large, most colics, most abdominal and most gastrointestinal causes of colic are medical in nature, have an excellent prognosis with appropriate treatment, but there is a subset of colic lesions that always require surgery to correct the problem. The problem with horses is we don't have an MRI or a CT really big enough to accommodate an equine abdomen. As the human population gets more obese, maybe we might have such a tool at our availability, but as of right now, we really don't have that luxury. And so in some instances, colic surgery is as much therapeutic as it is diagnostic. And what it really is, most surgeons will go through a ventral midline. Occasionally, you can go through a flank if you suspect, say, what's called a left dorsal displacement of the colon. It's a very specific type, or a uterine torsion. You can do it from a flank approach. But basically what it involves when it's diagnostic is a sequential evaluation by vision or palpation, because there's much of the abdomen you can't exteriorize. So it's a sequential evaluation of all structures inside the abdomen. It's obviously therapeutic, so you find a lesion and you correct it, and hopefully correct it the first time. And then really healing, essentially, and there are some nuances and differences with different types of colics, the type of lesion that you'll see in there. I'm going to go through some of those shortly. But the convalescence is essentially similar to all horses that undergo colic surgery, and that really just relates to the body wall healing and how that construct kind of heals in with a fibrous union on the midline there. So typically it's sort of 60 to 90 days. All right. So what types of colics are there? And this is where, I feel like a lot of people, they hear the word colic and they immediately go to the worst possible case. And that's really, we've all had bad experiences and seen those cases, but by and large, most of them are not a reason to panic. Calm heads will prevail, as people say. But We have simple obstructions, and I'm going to give you some examples of those. We have non-strangulating obstructions. So a simple obstruction is like your garden variety feed impaction. Non-strangulating obstructions is where, say, the colon is displaced in the abdomen. Hasn't compromised the blood supply at all, but it's still in the wrong position. So it means that the flow of ingesta and gas doesn't flow through properly, and so they can get gassed up and they can colic. Then you have what's called a functional obstruction, and that is where everything's in the right place, but it's just not moving properly. And that's your classic enteritis case. So I've heard proximal enteritis, or the more correct term is duodenitis, proximal jejunitis, and that is an inflammatory cause of colic. Then you have the strangulating obstructions, and these are the ones that you do need to have a little bit of a, not panic attack, but you do need to kind of think seriously about getting that horse to a referral center. And so they come in two varieties. It's basically a gradation of how tight the twist has gone. They start off hemorrhagic and they end up losing the blood supply and it becomes ischemic. And then other inflammatory causes, so you can have inflammation of the intestines, so that could be enteritis or colitis, depending on what's inflamed, or you can have just general inflammation in the abdomen, which is called peritonitis, when the peritoneum is involved. So lots and lots of different things that can cause it. So I'm going to just go through some specifics so that you've got some ideas about the myriad really of what you can find. And this is honestly why I love colic, because every single one of these cases is different. So simple obstructions, they could be mechanical in nature. I'm giving it away too early. So for example, this is a horse, this kind of like moon-shaped structure here in this horse is an enterolith. That's a stone that they grow over a period of time that tends to lodge in what's called the transverse colon. And in this horse, with that radiograph, it's a classic location for that. So that is surgical, but most simple mechanical obstructions are things like sand impactions or feed impactions, and they are very much medically treatable. And most of us, if not all of us, would always try to push a horse medically and not have to take that horse to surgery, because in the end, most cases, 95% of impaction colics should resolve with medical management. They might take some time, but they should resolve with medical management. Malposition, simple obstructions is where they say the colon is displaced. Again, a lot of people, the old school was to be like, you've got to cut every displacement. And now a lot of us really do things like trocharization and decompression and give them time and fluids. And actually a lot of these horses will fix themselves without the need for surgery. You've got to be pretty sure of the diagnosis and always potentially have surgery in the back pocket. But many of these horses will go on and do just fine with enough and prolonged medical management. And then functional obstructions, this is, again, a simple obstruction that's like your inflammatory causes. So here's one specific kind of unique one. It's not unique to Friesians by any means, but young, especially weanling age. This is your horse roundworm, Parascarus aquarum. So what typically happens is they're 5 to 6 month old weanling horses. They get dewormed. Then 2 days later, they are colicky and they've got reflux. And that's because you've given them a dewormer. You've got these adult worms that take about 3 months to grow to adulthood. And they pretty much, you killed them off and they float downstream, down the small intestine, and jam up at the end of the line like logs in a dam. And then everything kind of backs up in front of that. And now you've got a situation where nothing's twisted or anything like that, but you've got this kind of big worm bundle that sometimes needs to come out surgically. And here's a nice bucket of worms out of this weanling. Okay, the strangulating types, there's a whole slew of these, but at the end of the day, it causes a loss of blood supply. So the intestine is dying. These are time-sensitive lesions. You've got to make decisions quickly about whether that horse has a surgical option or not. There are some cases where even if surgery is an option, there is nothing we can do about what the problem is. And I had one of those today, actually, where so much of the bowel was dead and necrotic that it was not in the horse's best interest to recover him. He had 90% of his small intestine was twisted around the root of the mesentery, and I can't take out 90% of the small intestine and expect that horse to have a good quality of life. So these are time sensitive in an extreme way. But there's lots of different ways horses can strangulate, from herniation through different sort of like ligaments and mesenteric rents and things like that. They can twist it on themselves and around themselves, so a torsion versus a volvulus. There are some technical differences, but at the end of the day, they are essentially causing the same problem. Intussusceptions, if you've ever experienced that, is where one loop kind of telescopes in on top of itself. And so the part that's sort of inside here ends up losing its blood supply, and in the end that needs to be removed. And then other things that we see, strangulating lipomas are very common in older horses. Congenital remnants, so these are remnants of the yolk sac during embryology. Those can cause problems later in life, and when I say later, into adulthood, like as a 2, 3, 4, maybe 5-year-old. Just as these kind of extra sort of bands of tissue can end up creating a problem. So there's a lot of things that can cause strangulations, but there are a lot of ways that we can make that determination before surgery to make a decision whether they need surgery. Okay, so here's a couple of examples. This is a Friesian, this is obviously a stallion. You can see massive scrotal enlargement here. This was a ruptured scrotal hernia in an adult. This is always a surgical emergency, okay? Especially if you have any kind of desire to preserve the breeding function of that stallion. Not only is the bowel sort of sitting here under the skin, it's actually broken out of what's called the vaginal tunic, but the testicle there is compromised and it needs to come out, preserving basically the health of this one, because they can develop autoantibodies against himself and rendering him infertile. So those are surgical emergencies. This is a foal. This isn't a Friesian, but this is a foal with the same sort of thing. You can see those things there that look like a scroll there. Those are all individual loops of small intestine. Again, this is a surgical emergency because that skin there is being stretched, and so even if the intestine's alive and healthy and you put it back in the abdomen, that big area of skin there can go on and die, and that can be the reason why that foal ends up not making it, because they've got too much skin loss there. Down here is an example of a diaphragmatic hernia that can happen, especially in mares of parturition, and this is what's called an epiploic foramen entrapment. This is highly associated in horses that crib or have behavioral vices. So these are just examples of different types of strangulations that can occur. I'm not sure if this is going to work or not. Let's see. No, okay. But this is basically an intussusception. So this piece of bowel here called the ilium has telescoped into this kind of like fleshy sock here, okay, which is the cecum. So it's called an iliocecal intussusception. And so basically, if this video worked, you would be able to see that we're extracting that out of the cecum, but it's really thick and compromised and it needs to come out. This is basically what I was faced with today in a horse. Too much dead small intestine. It doesn't do it justice, honestly, without the smell that's associated with this. But this is unfortunately non-recoverable. This is a strangulating lipoma, very, very common in older horses, and this is a cute little section here that's got to come out. That horse should go on and do pretty well in most instances. That was a little bit on the small intestine. The strangulations of the large intestine, these are your typical large colon torsion or large colon volvulus. If someone's talking to you about, I think this horse has a torsion or a volvulus, they're usually talking about this, which is where the large intestine, which is all of this thing here, twists right down at the base, which is right inside the abdomen, and the average sort of, especially sort of Friesian colon size is about as tall as I am, which is about 5'11", 6 foot, doubled over on itself at a hairpin loop down the bottom here, okay? It's a pretty big organ, and all of this kind of discoloration here is blood. And so if you imagine, and this is why it's very hemorrhagic, these contents, and so these horses can lose a lot of blood actually within the wall of this tissue. And so they can be pretty sick afterwards. They also can absorb a lot of bacterial toxins. As you can imagine, like the lining of this organ has been very severely compromised, and so running into a problem where we see called endotoxemia, and I'll talk a little bit about that later. So this is an extremely serious form of colic, and this is the one that, you feed the horse the night before, you go out in the morning, and unfortunately they've passed away in the night. It's typically going to be something like this because it happens rapidly and they rapidly decompensate. So it's not surprising a lot of people have cameras and monitors on barns nowadays. Okay. So one of the myths about colic is that the horse will never survive anesthesia. They never wake up. And that's true to a point. It's certainly not the majority of cases. The actual reported mortality rates is about 1%, and this is based on some older studies. More recent literature suggests it's actually more like 0.3%, and that's coming down to basically, that's a 1 in 300, basically. And so, yes, colic is associated with a higher risk, but it really comes down to the colics that don't do well. It relates to the shock status. So herein lies huge differences, and why one of these people get confused or have misconceptions about whether colic surgery is good or bad. If I told you your horse has a displacement, they are unlikely to come in a shock with much of a shock status. Their heart rate may be a little elevated, but their blood pressure is good, they're well hydrated, everything else is fine. That horse is not going to have an anesthetic mortality. Versus the horse that comes in with dark membranes, a really high heart rate, you can barely feel a pulse, they're cold, they're clammy, the gums look purple. That is an extremely shocky animal, and that's what really relates to anesthetic mortality. So the fact that they're having colic surgery doesn't relate to mortality. It's really the shock status of the patient, and that's a really, really important factor, even from the surgeon standpoint, to say, is it even appropriate to put this horse through the potential for dying under anesthesia? Because if they're that compromised, then you probably need to do right by the horse and maybe consider euthanasia beforehand. Okay, so what is different that makes us actually have a much better outcome now? And that is that we recognize shock is a huge factor here. And so we actually spend a little bit of time with pre-anesthetic stabilization. We have better drugs nowadays that are what are called sympathomimetics, so they're much less cardiodepressant. They preserve blood pressure and heart rate much better than the older drugs and gases that we use. And we use an as low of a dose as possible approach. It used to be, when I went through vet school, that you knew that a horse got this dose rate of, say, ketamine or thiopentol as an induction agent. And now it's more like, no, what does this patient look like? How low can we get away with, essentially? So we're using the least amount of drug, because every drug has some downside, so we use as least amount as possible. The different ventilation strategies, so we almost always do positive pressure ventilation through an endotracheal tube, and then monitoring, really standard of care, the minimum standard of care is invasive blood pressure, so actually cannulating an artery, an ECG, and understanding, and having technicians and anesthesiologists actually understand what is going on with the ECGs, trace, blood gas assessment, understanding, okay, how can we better optimize oxygenation under anesthesia, and all of this is really aimed at early identification of problems with swift and corrective action. So here's an example of a young filly that, you can tell she's young, she's only got essential incisors. This is not a horse that had a strangulation. This is a horse that had a quote-unquote garden variety pelvic flexure impaction that was mismanaged and mistreated for about a week prior to her coming to me. And a pelvic flexure impaction colic, even if it went to surgery, 95 to 100% of those horses, owing to the fact that there is always a risk, but almost all those horses should have an absolutely slam dunk, excellent prognosis. This horse absolutely did not. And this is not a strangulation like a twist or a volvulus. This is a simple colic that should have been a slam dunk, fixed, cured, get her home. And she did. I was almost strong-armed into taking the horse to surgery. Owner knew that there was an extremely high risk of of her passing away, and it's exactly what she did. She got induced for surgery, and she decompensated immediately. So it doesn't come down to what is the lesion necessarily. It comes down to the shock status of the patient going into surgery or into anesthesia.
Dr. Hurcombe, I have a quick question here that we got from Facebook. The question is from Julie. The question is, I've heard that people say Frisians can die from general anesthesia when recumbent for too long. Is this true? If so, what can be done to prevent this risk? Or is this just a concern for any large horse?
It's, to my knowledge, and I think it's unsubstantiated in Frisians themselves, but it really is all large horses. Any draft horse, we're extremely very cognizant of times under anesthesia. We want to be as fast and as rapid as possible, minimizing times, having those horses. So the problem is that they die because of things like myositis or post-anesthetic myositis, where the muscles that are basically on the like the gluteals and the back and everything like that, they're kind of, the blood vessels there are crushed under the weight of the horse. And so if blood pressure and perfusion, more than the pressure, the number, it's actually more the perfusion of those tissues. If that is inadequate because of the patient's status or whatever, that makes that horse a much higher risk of getting what's called a post-anesthetic myositis and a post-anesthetic myelitis, where the same process of poor blood flow to the spinal cord occurs because purely the weight and probably poor padding of the horse while in dorsal recumbency or on their back. Not specific to Frisians. Honestly, I'd rather take a Frisian on its back than, say, a Clydesdale or a Percheron. But any big horse, that's always a big risk, and why you want to, the anesthesiologist needs to optimize as best as possible both perfusion and oxygenation, and the surgeon needs to be as fast and expedient as possible.
Okay, great. Thank you.
Welcome. So some surgeries can take a long time. If there's an extensive resection or a tight twist, and just sort of going back to what we just said, you want to be as quick as possible with being meticulous still. But one thing that we do recognize is some of these horses are going to require assistance in recovery. And so you need to let them do what they need to do to, some horses will fight head and tail ropes and things like that, but you need to also know when to encourage them and when it's inappropriate because the horse is physically that exhausted. And so that is where having a facility that can put a sling on a horse and assist them to stand. Also things like providing appropriate muscle nutrition, things like calcium and glucose, because your horses will exhaust themselves trying to get up and they're just too weak. And so that's where, having assisted recoveries has really kind of improved some of the anesthetic outcomes in these patients. Other surgical advances, I'll show you, some numbers at the end, but the numbers of survival are definitely improving, certainly really since, colic surgery was reported mainstream. Tissue handling techniques using a lot of lavage, a lot of what's called CMC, which is carboxymethylcellulose or belly jelly, basically is a nice lubricant that the surgeon can use as he's handling or she's handling the tissue. Stapling equipment usage, so that silver thing there is an I-1100. These are all human products, but these are devices rather that they make things like reconnecting bowel together fast, clean, and minimizing anesthesia time again. Using blood when needed. So here in my hospital here, I've got a blood donor who's been blood typed to be essentially as best as you can find to be a universal donor. And so I had a horse last week that I took a kidney out and needed a blood transfusion. I've learned over the years, if there's ever even a thought about the horse needing blood, give the horse blood. It probably needs the blood, and that is truly life-saving in these animals. There's differences in things like technique of the abdomen preparation, so our incidence of incisional infections is definitely down using certain types of antiseptics. And then also better decision making, knowing what you could potentially leave in, what doesn't need to come out, what absolutely needs to come out, knowing when to push on or not, what is really in the best interest of the horse. Things are often technically possible, but they're probably not ethically possible or ethically responsible, if that makes sense. So I think really being an advocate of the horse and making sure that you're making the right decision also helps. Some misconceptions is that colic surgery is a death sentence to an athlete. It's absolutely not true. Well, to a point. They're never the same after colic surgery. These are probably things that we've all sort of heard and have maybe even said. This horse was said to be grand champion into colic surgery. I can't tell you the number of times I had quarter horses in my old job that were meant to go to the quarter horse congress and be the grand champion. Okay, I can't perform miracles. Horses never compete at the same level again after colic surgery. So the question is there actually any evidence to support these opinions? And the reality is, literature, there's some good retrospective papers out there, especially as it relates to racing thoroughbreds. There's 3 really good papers. There's one on sport horses and show jumpers out of Europe that's actually very well done as well. The quick and dirty of that is that about 85% of horses that undergo colic surgery will go back to doing the vocation that they were prior to surgery and at a similar or better level. The big caveats are the show horses where any kind of cosmetic blemish, so if they have a small incisional hernia or something like that, that can often change what they need to do in terms of an occupation. There are obviously definitely, and these are horses that obviously get through surgery, through the recovery period, and go home. There's a whole kind of slew of things they have to overcome before that happens. But of the horses that survive to go home, most of them go on and do to the same or expected or better level of work. So here comes into the Friesians. Obviously, I'm talking to the experts here. They originated in the Netherlands. They've been tightly inbred for over a century, especially since like World War II, apparently. But in a general equine population at Utrecht, about the hospital population, the equine hospital population there is about 7% Friesians. The population in the Netherlands is about 7%. In the hospital, the population of horses that they saw at Utrecht was about 7% Friesians. However, there is absolutely a higher incidence than just simply 7% of certain clinical problems among Friesians compared to the general horse population. So some of it's proven, some of it's in the literature, others are just, it's more of an epidemiological incidence. So there's a reported increase in incidence of certain hereditary disease, and we're going to focus this obviously on the GI system, things like dwarfism and hydrocephalus and things like that. That's pretty well established. But one of the problems is, and again, I'm probably preaching to the choir here, is there is a growing body of evidence of low genetic diversity and variability. So microsatellites are markers of genetic richness of DNA among any species, but in this case, Friesians. And the development of certain lesions has certainly been linked to collagen defects, whether it's aortic pulmonary fissures or pleural fistulas, maybe even megaesophagus. But it seems to be that there's a growing body of evidence that part of the genetic mishap here in the breed is a collagen defect or collagen 4 defect, because there's lots of different subtypes of collagen. So there's certainly a building evidence for certain types of colic. Part of it's anecdotal. If you talk to any experienced equine clinician that has ever dealt with Friesians, we all have some kind of story to tell about that case that was atypical, unexpected, threw a curveball at you when it should have done well. So there's definitely some anecdotal and clinical experience that tells that is out there, and there's a perception that Frisians are a little bit different. And there's also some things that are reported in the literature. I guess the building evidence, at least from my perspective and certainly what I've seen, is that there is an association with the breed and proximal lesions. And that is the problems associated with the esophagus, the stomach, and the duodenum. I think things like colitis can happen to any horse, and maybe there are, that's more to do with the bacteria in the gut and what's called the microbiome. But when it comes to actually the physical structure of the anatomy, I think the esophagus, stomach, and duodenum appear to be a little bit unique in the Frisian breed. The other thing that's we have to consider with Frisians is that they are, at least in my experience, a very pain-tolerant breed. They're typically very stoic, and this is to their detriment in many ways, in that I'll have a thoroughbred across the street here at Belmont Park that will literally have gas stuck sideways and be rappelling off the wall. That horse just needs some buscapine, some thyme, some fluids, and will be just fine. But it has declared himself as very painful. Same horse, a Frisian or any other sort of draft breed, really, they can stand there and literally rupture their stomach in front of you with barely, making a movement. And so the thing that I harp on, certainly students and interns and residents, as well as for myself when I'm dealing with any draft horse that comes in for colic, is I rely heavily on objective findings rather than the subjective. If the heart rate is even mildly elevated, that is significant for me for that there is something more aggressive or more serious going on than if the horse doesn't show me any clinical signs. Even if he looks comfortable and wants to eat and isn't showing any of the classic colic signs, if the heart rate is elevated, if the respiratory rate is elevated, if there's any kind of inkling of distension, both with the abdominal contour or anything like that, those are things that you have to listen to, because they can't hide that, and that's the physiology of the body. So I guess that's one thing with people that deal with these horses: really look at objective findings. Okay. So specifically on, just going through starting from some of these specifics, with the esophagus structure and function, just quick and dirty review. There's 3 regions of the esophagus: the cervical, the thoracic, or the abdominal. You could say cranial, mid, and caudal, or proximal, mid, and distal. It has relevance coming up here shortly with megaesophagus. They have 4 layers, like a typical sort of tubulointestinal structure. In the distal part, or the part that's sort of like in the thorax and into the stomach, it's very much smooth muscle. And there's 2 main sort of like types of smooth muscle: longitudinal, circular. It's under typical autonomic control in terms of the nervous system. It has no digestive function per se. It's really just a conduit for food from the mouth to the stomach. So in the Frisians, certainly megaesophagus, and I know a lot of you probably know quite a bit about this, but megaesophagus can affect any animal, but it can be congenital. It can be related to something called persistent fourth right aortic arch as a congenital lesion, which basically is this constricting band over the top of the heart that basically kind of strangulates down or kind of tethers down the esophagus, and so you will have progressive dilation, and with dilation and stretch comes atony, which is an inability to have normal peristalsis or even any peristalsis or movement. And so any breed can have this, but Frisians appear to have a much higher prevalence. And what results happen is you get esophageal impaction. As fluid builds back up from that impaction up the esophagus and back into the pharynx, a lot of horses will aspirate feed and saliva into the airway. They'll get aspiration pneumonia. With progressive impaction of the esophagus, you get a lot of pressure on the wall, and it squeezes out blood vessels through the layers of the esophagus, and so you get what's called a pressure necrosis. And so you can actually get a tearing or a rupture of the esophagus. And if that happens, it's an extremely serious problem because the animal can then go on to develop septic sequelae or infection through what's called the mediastinum if it's in the chest, which then extends to the pleural space. Just basically, it's a pus factory in the chest, and they get toxemic and can die. So it's extremely serious. So there's the clinical incidence. There was an abstract out from the proceedings in the World Equine Veterinary Association out of Utrecht. So this was the clinic that also reported a 7% Frisian hospital population. So in this case, though, they had 35 cases of megaesophagus. 31 of them were Frisians. That's certainly more than 7%. So this is more than just flipping a coin, Frisians associated with having this, that this is compelling epidemiological evidence that this is a real problem. In the second clinic, they were all Frisians that had the problem, and there was quite a variable range in the age of horses that presented for this. But here's one very breed-specific issue. This study looks at was essentially a necropsy study. And I will apologize in advance. Some of my videos and pictures are kind of graphic, really to illustrate the point. So if there's something particularly graphic, I'll warn you. You can kind of like click out for a second. But there's some surgical videos and things. But in this study, this was a necropsy study. So they basically went back through records of horses with severe esophageal lesions. And Frisians had caudal or very distal. It wasn't the first part of the small intestine where there's sort of a mixture of different muscle fibers. It's the distal part, the part that goes through the chest, into the abdomen, into the stomach. They had really severe muscular hypertrophy or thickening of that wall, that muscular wall of the esophagus. And so they likened this a little bit to Alport's disease in humans, which is possibly linked to a collagen IV defect. But you can see here that from this table, there was a much higher incidence of severe esophageal lesions and muscular hypertrophy when compared to all breeds, 35% versus 1 to 2%. So again, this is a highly associated breed predisposition.
Dr. Hurcombe, we have a quick question from the audience.
Yes.
Julie, I'm going to unmute you. If you can speak, go right ahead. Julie, are you there? Yeah.
Yeah.
Go ahead.
Can you?
Yep.
I just had a question when you talked about this being so prevalent in the Frisian and in the location. Could that be because of their conformation with the vertical neck? Could that have anything to do with it?
That's a really interesting point. I don't know if anyone's looked at sort of kinematic esophageal pressures, but I don't know the answer to that, but that is an interesting theory. You can do what's called esophageal manometry because whenever you get muscular hypertrophy, it's usually related to a pressure differential. The muscle basically will thicken in response to pressure. Same happens in the heart, same happens in the intestine. So I wonder if that is because when they go back and look at some of these candidate genes for collagen defects, they haven't done sort of like the pedigree studies yet, for this specific issue, but histologically or under a microscope, the collagen isn't necessarily bundled incorrectly or, at least based on routine sort of staining. So I wonder if this is, you could be completely on the money here, that it's some sort of like conformational pressure related aspect. The only thing that doesn't support that necessarily is when the part that's affected is very caudal. And so as it goes through the chest, it pretty much kind of straightens out. As it then traverses through the diaphragm. That would be the only kind of thing that I would say that wouldn't support that theory. But I mean, you bring up a really good point that usually hypertrophy of the muscle relates to pressure, and pressure can be related to conformation.
Okay.
Dr.
Yeah.
Fox is here. I don't know if she has anything to add to that, or we could come back to that at the end of the presentation. I've unmuted you, Dr. Fox, if you want to make a comment. Okay, let's skip on, and we'll come back to that if we have time.
Okay, sure thing. So this is, again, from that paper that looks at, you can see, this is down here is normal. This is grossly abnormal, thickened, hypertrophic muscle. This was the very first part of the esophagus, the mid parts of it as it kind of like goes around the curve into the thorax. This was one of the clinical examples they had there of just having such severe pressure necrosis that it actually caused it to rupture through all layers of the esophagus. So the horse we saw upstate, very similar findings. The horse had unfortunately had a rupture further down here in the thoracic part of the esophagus, but you can see here on cut section really, really thick muscular hypertrophy with a very, very tiny lumen. Okay, so that's all the conduit that there is for that horse to you basically get food down into his stomach. So that's why if the horse realizes over time that, you know what, I can't eat a huge kind of gulp of food, they're very slow eaters, they'll eat very little. So sometimes the more chronic form of this is just weight loss. Because they know that if they eat too fast, then they're going to feel full and fill up and start coughing and seem like they're choked. So just on that, the clinical signs look, in many cases, like an esophageal obstruction or choke. More often than not, you'll have feed and saliva from the nares, just based on the anatomy of the epiglottis, the soft palate and the throat. Things tend to come out the nose rather than the mouth. But the classic choke signs are retching, coughing, nasal discharge. Odynophagia is where you see the horse sort of like gagging down, like pulling down on his neck as a sign of esophageal pain. Sometimes you'll see them have repeated attempts to swallow. You may see a big visible bulge in the neck. And if it's ruptured, you might feel crepitus or sort of like bubbling under the neck, where air has now escaped into the different tissue planes. And again, some of them won't show choke signs, but more like weight loss and wasting. This is an example of a barium study, so you can see huge dilation of the esophagus. To put it in perspective, that's the windpipe down here. This is multiple times the size of that in this horse. So diagnostically, certainly clinical signs are supportive. Endoscopy is very useful. You need a 2 to 3 meter flexible endoscope. Ideally, just because anytime you have an obstruction and then distension ahead of the thing, pre-stenotic distension causes a degree of, quote, ileus. And so what we recommend is to assess the likelihood of a motility disorder or a likelihood of an abnormal, persistently dilated esophagus. After the obstruction is resolved, we would then rescope that horse without any sedatives on board to look at what the motility looks like, what the scope looks like. Contrast radiography can be very, very useful, sort of like giving you sort of a nice sort of outline of how extensive it really is. Because when you're looking down a scope, you don't really have a huge appreciation of like the measured dimensions of the dilation. You just can see that it's a big chasm. But with the radiographs, you can see it. So here's an example of a horse, of one of the Friesians I've had here that's fairly normal looking proximal esophagus. This is the scope going down just after we swallowed it. Looks pretty normal. It's contracted down, nice folds of the lining there. As I've got to the mid, this is sort of starting to dilate out a fair bit. This food, if I actually had a loop of it, actually was kind of reflexing back up and back down and back up and back down. So like as he was like differences in pressure or something, it was really crazy. He was acting like a cow, how it chews its cud. It basically regurgitates and swallows, regurgitates and swallows. It was crazy. And then this here is the very distal part. In the back of the image here is the entrance into the stomach, but there was this massive just massive dilation of the distal esophagus in this horse. And here on the radiograph, this is that massive dilation. It's almost like you would imagine it's like a hiatal hernia where some of the stomach is herniated into the chest. It wasn't, because I could see the cardiac sphincter, which is basically where the esophagus enters into the stomach, very easily. And this is actually one of the other walls of the stomach here. So it's not a diaphragmatic, a hiatal hernia. This is truly massive esophageal dilation in this horse. And all of that there, let me sit back, all of that here is feed, gas, fluid obstruction. Crazy. This horse, believe it or not, is actually still alive and has been alive. I've managed him now for about 3 years. I saw him shortly after I got here. And he is essentially fed from a height, just like you do with a dog with megaesophagus esophagus. He's fed from a height. It's basically soupy gruel. It's multiple small frequent feeds, which is he has a very dedicated owner. And the horse is actually doing pretty well. You can formulate some of these liquid diets to really achieve much of the crude fiber content they require with different products. So you can manage these. You're never going to cure these. But I think a really, really soupy or liquid diet is essential. Otherwise, they have a higher risk of rupture, I think. So in any choke or obstruction, heavy sedation, you want them as sedated as to have their nose below their shoulder. So if they are resisting a tube or anything like that, throwing their head up, they need more sedation. You've got to have their nose below the shoulder. Otherwise, they will aspirate a lot of the fluid that you're using to lavage that obstruction out. I use a lot of spasmolytics in these cases, so Buscopan. If we have people from Europe listening in, we don't have compositum here in the States. It's just the scopolamine fraction. There's no dipyrone, so it's just the spasmolytic part without the non-steroidal. And then I often put lidocaine directly down into the esophagus, onto the mucosa, just to kind of, I think it stops them spasming so much. And then you have to lavage them with water only. There's a temptation to lubricate it with oil or something. Absolutely the worst thing you can do if they aspirate that oil in the lung is a death sentence. Rarely do you have to do this under general anesthesia. Occasionally, if you're really worried about them fighting you, it's an extensive impaction, it's been going on long-standing, you need a little bit more control, plus the benefit of relaxation from the general anesthesia. Sometimes we'll do that, and this is obviously isn't a Frisian here, but this is a Tennessee Walker. And essentially we had to do that. You basically protect the airway with a nasotracheal tube, and then you have, an orotracheal tube, and then you have a nasoesophageal tube that we can then basically use as a water pick to basically get this unobstructed. I, fortunately, knock on wood, have never had to resort to anything like this, like a gastrotomy, which is we actually have to open the stomach and go back up the other way to relieve the obstruction. I have colleagues that have told me they've had to do it, not specific to a Frisian, but in general with bad chokes. Stomach surgery almost never is a good thing in a horse. Moving on into the stomach, quick review. Remember, in the horse, it's divided into two parts, the non-acid producing part of the squamous part and the acid producing part of the glandular part, and separated by this anatomical line called the margo plicatus. There are different regions of it. It does aid in protein digestion and mechanical digestion, and it has about a 12 litre or so, 12 to 14 litre capacity in an average horse. So there's some loose, I would say, but I think we all have at least an anecdotal experience that I've seen a number of Frisians with gastric impactions. It is typically an uncommon cause of colic. It can be primary from certain types of feed that are ingested. So like beet pulp that hasn't been soaked is a really common one here. We see persimmon fruit, which is this thing here, which is down in the south of the US. and then idiopathic and hereditary. So this might be more where our Friesians might play into. Again, unproven, but there are some studies and findings on necropsies that might suggest, again, a muscular hypertrophy aspect of this disease in Friesian. The other is secondary impaction related to atony, because they have another primary reason for colic. We see that a fair amount, but those are they're typically not as bad. Other risk factors, bad dentition, type and feed, that sort of thing. So you'll find these horses have reflux. You won't find distended small intestine on rectal or ultrasound, and this is probably one of the defining findings from your veterinarian, that typically reflux is associated with small intestinal problems. And if you cannot find distended small intestine on your ultrasound or in your rectal exam, but you've got a lot of reflux, chances are it's gastric in nature, and one very common reason, or most common reason, would be gastric impaction. So you can see a stomach wall on ultrasound as it kind of like extends further back on the left side of the horse, and then you can certainly see it on gastroscopy. So here, unfortunately, is a necropsy from a colleague of mine in Germany. This was a young Friesian that had severe and persistent gastric impaction they just could not get to resolve. And you should not be able to do this to a horse and actually get the outline of the stomach. This is the stomach at necropsy. Just to give you a perspective, this is sort of a normal-ish size spleen. This is a massively distended stomach. This is the stomach kind of ex vivo, and it's got this kind of this partial seromuscular tear, okay, through here, right by the esophagus. And this is all of the contents that was just packed in there. And so, this doesn't just happen overnight. This is chronic. For a stomach to get this size, it does not happen acutely. It happens over time. And so, like a lot of impaction type colics like this type, gastric and particularly cecal, they are called the silent killer for a reason. And that is because they will go undetected until it's a crisis point. And so, again, if that horse is just standing there, but that heart rate is slightly elevated, for me, that warrants in-depth investigation. So there was a study that looked at primary gastric rupture of 47 horses. The prevalence in their population was around 1 to 8% based on a culmination of different studies. Friesians and other drafts. So I'm not going to label them with the scarlet letter essentially, but Friesians and other drafts were overrepresented. Some, discussion of this is it due to the stoic nature? Absolutely could be. And I've seen a fair share of other draft breeds that have had ruptures, and they're really giving you not much warning. Versus hereditary predisposition. And the part that kind of goes along with that is that many of the horses in this necropsy study, because essentially this is uniformly fatal, had muscular wall hypertrophy similar to the distal esophageal hypertrophy observed. This is, again, this is a horse that had distal esophageal hypertrophy as well as a gastric impaction that upstate Cornell saw. Could it be a similar pathology seen with megaesophagus? We don't have the conclusive evidence, but again, it's this growing body of clinical evidence that Friesians seem to have proximal GI issues. So treatment for gastric impaction is lavage, lavage, lavage. You cannot lavage enough. You do need to be very cognizant of what you're putting in and making sure you're getting out what you're putting in. Otherwise, you over-distend it and you can rupture them. But the goal is to soften and evacuate, soften and evacuate. It can take several days to do it slowly, methodically, without risking the horse. Some have advocated the use of Coca-Cola because of the phosphoric acid nature and its ability to sort of like eat through things. And when impacted material kind of sits stagnant, it gets covered in mucus biofilms and things like that, which make it a little bit hard for fluid to penetrate, especially things like water. And so some advocate the use of like an effervescent substance like Coca-Cola with phosphoric acid, that it actually might help break some of that biofilm barrier down and cause it to soften up. I definitely thought that I had given horses a bit of a caffeine jitters doing this. So I have gone to caffeine-free Diet Coke doing this, but it definitely is one of those things that you could consider. Surgery for gastric impaction, I would avoid like the plague. If it's your last-ditched effort, if it's your last resort, then obviously you can do it, and it is reported. I've certainly never had to do a gastrotomy for impaction. It's just so uncommon. Before this talk, I sent out an email to the listserv of a couple of the ACVEC large animal listserv, and I asked how many people have done what's called a gastrojejunostomy or gastric bypass in an adult horse, and then of those, what were the breeds? And it was very interesting. There's a smattering of people responded back to me and said that they have done, 1, 2, maybe 3. One person had done 3. Every single one of those people have said it was a Friesian. And I gave them no lead into this at all. There's something to this. I've personally done 1, and it's one of those things like nobody wants to do this, but if it's the only option, if you've got a severe outflow obstruction, whether it's the horse that I did had really severe enteritis and actually ended up fibrosing and scarring down a lot of this initial segment of the small intestine with both adhesion but just more scar and fibrosis, and so needed a bypass. So really the indications for this are either severe gastric impaction, duodenal stenosis, or outflow tract obstruction, or persistent reflux. Again, this is just one of those like interesting things that gastric surgery is really, really uncommon in horses. Colon, small intestine, super common, but stomach, really uncommon. And of the 10 or so people that responded to me, every single one of them was a Friesian. So I think we need to go back and look at those cases and just see what were the reasons for it. So I just want to show you a cause of. If there are questions now's probably a good time, because I'm going to segue into a non-GI cause of colic.
I don't have any questions right now, but we are about within our last 30 minutes. So depending on how much time you think you're going to need,
I'll push on.
you may want to go on to your outcomes.
Okay, yeah. So I'll push through this fairly quickly. It was a cool example of a non-GI cause of colic. This horse, a 5-year-old mare, so she's not that old, presented for intermittent colic of a couple of days. Really good management, no reflux. Treated just with standard sort of like medical management, flunixin or banamine or phenidine, wherever you're from, mineral oil. But when we looked at her gums, she was extremely pale, okay? She had a hematocrit of 9%, normal's around 35 to 40, and a lactate, which is a marker of perfusion, was very high, sort of going along with having not enough red cells to supply oxygen to the tissues. So on her ultrasound, she had this like classic swirling. This isn't a loop, but this, you have to believe me, this was sort of like swirling around here. This was basically a hemoabdomen, so she had free blood in the peritoneal space. She had this kind of strange mass thing here that measured, pretty big over on the left-hand side. So why the colic? Well, part of it is peritonitis, just because you've got free blood in this abdomen, but the other thing is the gut, all of the gut, is one of the most oxygen-sensitive tissues. And so anytime there is a reason for low oxygen, in this case it was hemorrhage, the gut tends to want to shut down, and then when it shuts down it gets distended and they get colicky. So not all colic is a primary reason for the abdominal pain. There are sometimes secondary reasons for the pain. And so we immediately diagnosed her with a hemoabdomen, and she needed a blood transfusion. So we actually found friends of this owner who also had Friesians and had an unrelated, as close as we could determine, gelding that we did a major and minor cross match with this mare, and basically gave her, I think it was close to 12 liters of blood and to stabilize her, and then took her to surgery because this mass we believed was bleeding. And so I'll warn you now, this is a little graphic. So this is what I was faced with. So you can see there's a lot of blood. We've literally just started opening the abdomen. It's wild. A lot of that is fluid with blood. It's not all blood discussion. Yeah, there's stuff that was already in the abdomen, not stuff that's actively bleeding out as we go. But it just goes to show she had this huge abdomen full of blood, and peritoneal fluid. This is what we found. So we're using something called a ligature here to help ligate this pedicle off of this mass here, okay? And this is, one of the advances that we use now is that we no longer have to do a ton of hand ligation for things. We use a lot of other biomedical instruments that help facilitate and make things faster, cleaner, and quicker. So that was extremely useful. And so what this was a granulosa cell tumor. This is the ovary. This is the left ovary in this mare that basically had a vascular blowout, and that's the normal ovary on the right side. And so she's pretty damn young for an ovarian tumor and a granulosa tumor at that. And this is the mass. So once we kind of got the pedicle of this ovary ligated, the mare received more blood on the table. She ended up doing totally fine until a couple of weeks later. She actually came back with a really severe Clostridial infection from a vaccine that was given, I believe. But aside from the abdomen side of the equation, she actually did pretty well. It was a very cool case. So again, this is just one of those examples that they're not all GI in nature. So if your horse does have surgery, why do some of them still have poor outcomes, even if you do everything right? And the short-term complications we see are pain, and that can be from just from distension. Ileus, which is where the gut has to kind of remember to kick back up and have normal motility patterns. Ileus is where that motility pattern is depressed or decreased. We often see that more so with small intestinal lesions over large intestinal lesions. You can have anastomosis issues, so reconnection issues, fever, incisional swelling. These are not the typical pluck a chip out of a joint, go on and do just fine. There's the roller coaster of the recovery period, and this is where I really believe these cases are won and lost. Is very diligent monitoring of these horses and jumping on problems as soon as they're recognized, and that is looking at the horses with a very critical eye. Long-term complications, you can have adhesions, which often is related to repeat colic. Really depends on what the problem was to begin with. You can have incisional problems, both infection and hernia. If you're infected, you're about 65 times likely to get a hernia. And then if you have to take out a ton of small bowel, for example, you might have malabsorption issues. So this is really where the case is won and lost. You really need to early identify potential complications, really good pain control that helps with, I think, motility. You really utilize a 24-hour ICU care facility. I think this is a newer thing well, not new, but it's certainly more in step with human surgical ICUs, where early enteral feeding, where possible, makes the gut remember that it's got a job to do and to do it. Using IV nutrition where appropriate, if you've got a horse that can't tolerate enteral feeding. And then I think this one is undersold. I think there are some very short-term but very correctable problems if you just get those horses back to surgery quickly to tweak some things. Early recuts do, at least my experience, like usually will result in good outcomes. One of the things that I think a lot of us have become extremely obsessed about, because horses love to make adhesions like you and I do as humans, we make adhesions very well. One of the things that we're very obsessed about is adhesion prevention. So doing things like hydroflotation. So this is basically an example of, you fill the abdomen with a lavage fluid after surgery. They have an abdominal drain. You basically fill the abdomen up with sterile fluids and physically distend these loops of intestine apart so they're not physically sitting on each other and sort of like wanting to glue down to each other with sort of protein and things. The other thing we use are things like seprafilms, which is a certain membranes we put on. So here's an enterotomy. So we put anywhere where the suture can be a potential adhesion site, we put things like seprafilms on there. So this is just really just to illustrate that there's a lot of things that we do nowadays that I think have been instrumental in changing outcomes. Prokinetics, this is, for me, early implementation is key. Some still think that only give them when the horse declares that it's got a problem. I think my personal feeling on that is if they've got the problem, you're already behind the 8 ball. So for me, I always will always put them on a prokinetic regardless to get the gut moving ASAP. And that's really the goal here, is get the gut moving. Gut that sits there, distended, stagnant, sitting on top of itself, getting inflamed, wants to stick to itself. If you can keep it moving and gliding over each other, you're much less likely to have it stick to itself. And I'm not going to go into all of these different things, but there's a lot of different things that we do nowadays to really try to promote movement and stopping ileus. This is unique to all horses, not specific to Friesians, but so endotoxemia. So this is just a really neat sort of illustration of what sort of endotoxin is. So this is here looking at the cecum, okay? And inside the cecum, you've got the fluid and ingesta and all that kind of stuff. And within that is a normal bacterial population. So here's these bacteria. And zooming in on the wall of the bacteria here are these little molecules here called LPS, or lipopolysaccharide, or the other term is endotoxin. Whenever those bugs are unhappy, and that can be because of antibiotics, it can be because you've got damage to the wall, the gut, some kind of stressful incident to the intestine, this molecule here triggers a massive inflammatory reaction in the horse. And so what happens is, so you've lost the normal barrier down here, so you've got exposure of these vessels in the wall of the gut. This toxin is now, because it's got lipid in it, will go across into the blood vessel really, really easily, okay? So there's kind of mist of nastiness coming in here into the vessel, okay? So all these little kind of endotoxin molecules form what's called a micelle, okay? This little docking protein comes and shows it to the inflammatory cell or the immune cell in the horse. And this thing here called a monocyte is what triggers a huge inflammatory reaction. Horses, as a species, are so exquisitely sensitive to endotoxin. The manifestation is that they get fevers, they thrombose catheters, they get laminitis, they founder, they lose their feet, and they die. And so we need to be better, and we are getting better, but we have a long way to go to basically stop a horse that has this, okay, which is the large colon volvulus, from absorbing all the toxins that are sitting within here back into the bloodstream. And so there's a ton of different things that we do nowadays to really try to reduce the ability for that endotoxin to get access to the immune cells of the horse. And that is from putting biosponge. If you've heard of that, we put it directly in the colon at surgery to basically absorb the toxin with a lumen. We get these horses in ice immediately. I was involved in one of the studies that looked at ice or cryo or digital hypothermia to prevent laminitis with colitis cases. Horses that get ice continuously are 10 times less likely to founder if you don't have them in ice. Polymyxin B, a really useful drug. I give this to the horse on the table when I realize that, yeah, they got something really bad. And that binds directly the endotoxin that's already been absorbed into the bloodstream. So there's a lot of things that we do nowadays to really stop the triggering of this inflammatory reaction. So the things that really affect poor outcome is not necessarily the surgery. It again comes back to the shock status. And what's been shown in the literature is heart rate at admission coming in, the lactate at admission, plus all of those other clinical markers of perfusion and oxygenation. Those are really important. And a lot of this is a function of both the severity of the lesion and a function of time, okay? How long has it been going on? You could be the best surgeon in the world, but if it's been going on too long and all of those inflammatory pathways have been ramped up already for hours and hours and hours, you could be the best surgeon, the fastest and the most meticulous in the world. That animal is already behind the 8 ball, okay? Things that don't affect outcome are duration of surgery, duration of hospitalization, and having a previous colic surgery. That's proven. How do we optimize outcome? One is early identification and quick treatment. That is the #1 thing. If you can train your friends, your clients, that the worst case scenario that you send the colic to a clinic that has just literally a little bit of gas is you've got transportation and a hospitalization fee for essentially an overnight stay. The best case scenario is that they are at a facility where if they need more advanced intervention, that you get into it quickly, you have the best possible outcome for the cheapest possible price, and that's been very well established. Minimizing hernia risk, things like hernia belts I think are quite useful, especially with thin abdomen horses, or those that have had maybe a more difficult recovery. Really good stabilization before surgery, and then goal-directed post-operative therapy, like say for laminitis and endotoxemia. So is there any evidence that we're improving survival? So I just took some of the reported survival rates for 2 really common and very serious types of colic in the horse. One is horses that have small intestinal resection. In the sort of mid-80s, it used to be about 25% of horses survived. Okay, that's abysmal. With changes in things like anesthesia, pre-operative or pre-surgical stabilization, post-operative management techniques, you can see that there is definitely a much higher survival rate nowadays. So you're well into the 80s now, and I would suspect if we looked at our numbers now, we'd probably be approaching sort of mid-80s to even higher. A lot of that comes down to you guys and to owners, like recognizing something is not right quickly and getting them to a surgical facility. Large colon volvulus, where that entire large intestine is twisted. Again, early in sort of mid-80s, 30-something% of horses survived. Now we're close to 90. That's almost like a displacement. Displacements are like 95 to 100%. So we're actually getting a hell of a lot better at getting horses to survive. It also probably comes down to good decision making. So, truths about colic: timely delivery of urgent care greatly improves survival. Again, waiting and hoping doesn't do anything. If it's surgical, waiting increases morbidity. They have more problems after surgery. They have more costs associated with that, and you may end up having the worst possible outcome. Many types of colic can be related to what we do to them. For example, gastric ulcer disease. If we impose this meal feeding system on them, where horses naturally, they're physiologically designed to graze 24/7 essentially. They constantly secrete acid consequently because of that. We then impose stably meal feeding, and there are periods of time where some horses have literally nothing in their stomach, yet they're already secreting acid the whole time. No wonder those horses have a high incidence of gastric ulcer disease. So sometimes what we do to them actually causes more problems. And the other truth is that colic treatment can be expensive. There are definitely anticipated and unanticipated complications. Some horses, it's a reality that will die despite best efforts. And I really think a lot of this comes down to genetics. I'm not talking about like collagen 4 defects or anything like that. I'm talking to how does an individual horse respond to, say, something like endotoxin? How overzealous or crazy does their inflammatory response go? Because not all horses respond the same way. And I think that comes down to the genetics. Responsibilities. Owner bears responsibility for requesting veterinary help. If we don't know, we can't help. Referring vets bear responsibility for timely diagnostics and appropriate treatment recommendations, which may mean referral. Specialist veterinarians bear the responsibility to implement timely diagnostics and therapeutic measures. And it's really, I think, I hold it extremely important as my job to tell owners that the reality of what the prognosis is for their animal, what the financial implications are, and what they have to be aware of what they're going into up front. And I would never judge somebody that decided euthanasia over surgery, especially for a horse with a shocking status, because I think in this profession we're actually lucky that we have that as an option. Myths about colic: age is a disease. Comorbidity and deteriorating cardiovascular status or shock status, that is what is the disease here. So if the horse has bad heart disease, if it has severe arthritis and it has difficulty getting up and down anyway, it's got other comorbidities, those are things that we absolutely have to think about before potentially treating even a bad medical colic. You've got to look at the whole horse. Colic surgery is a death sentence. Again, I've shown you some figures that show that isn't necessarily true. And horses are never the same after having surgery. Again, there's evidence that 80 to 85% will return to a previous or better level of work. So what are some preventions and things that you can do, some tips to help reduce the risk? So one is plan for the worst case scenario. Provide contact information at your barn for who your shipper is, who your vet is, who your referral center is. Obviously have a good working relationship with your vet. And honestly, having a trusted relationship is extremely important in that regard. If you don't trust the veterinarian, find a new veterinarian. In my population here, I have enough clients that complain, that wish that they had been referred sooner. And so it's my job to sort of, educate a little bit more of the referring vet population here about some of these things. And not all of them. I have some awesome really great vets too. Know how to get transportation, whether it's your own trailer or whatever, how to get to a referral center. And I think this is an important one. Set your limits ahead of time. When you're faced with this acute crisis, it's often a very emotional driven decision. And if you need a second person to come along to be a voice of reason in some regard, do that. But some limits are surgery, yes or no, or maybe, depending on the prognosis. And I think that's probably the most appropriate, is maybe, because colon displacement, that horse will do well. A colon torsion that's really sick and shocky, maybe not so. You might decide, if it is surgery, you might do an exploratory look and see if it's easily corrected, then push on, versus more challenging to correct, and that might be the difference between, say, resection versus no resection. Okay. So 10 ways to help prevent colic. One is establish a daily routine with your horse. Horses, I guess like kids, respond very well to routine. Feed high quality diets, primarily of roughage. That is what Mother Nature or God or whoever you believe in has designed the horse to ingest. They are herbivores, they are foragers. That is what their physiology is made for. Avoid feeding excessive grains and energy-dense supplements. It's an extremely tight balance between the horse's workload, what you're asking of them. Is it beyond what is what typical of a horse, say, in a field? I'm not saying energy-dense supplements are bad. Ration balances, I think, definitely have their place. Horses that are on convalescence for, say, orthopedic injury, that lose their top line, I think you can do a lot of good by giving, say, a prognathous ration balancer, but do it all in moderation. Divide your daily concentrates into at least a couple or many more smaller meals. Big concentrate slugs into especially the stomach, and if they certainly reach the large intestine, where the powerhouse of the bacteria are, they'll see that concentrate and they will think it's Christmas. All of that sugar, potentially what's called non-structural carbohydrate that's often found in concentrate feeds, that's like candy to the bugs. And if they get a big slug of it, they will over-ferment it. You'll get gassy. You can get acidotic. They can then run into problems with the lining of that intestine becoming inflamed, and then they can absorb toxins. You can get diarrhea. I know I'm sort of like being the grim reaper with this, but it's super important that I think with grain feeding you do it with many smaller meals. Establish really sound parasite control, and for me that is doing fecal egg counts every 3 to 4 months with a plan that if they're less than 200 eggs per gram, I don't deworm them, but every horse should have a dewormer that includes praziquantel at least once a year, praziquantel and ivermectin at least once a year. Everybody has a little bit of their own sort of like thing here, but sound parasite control, and this is really a farm level basis, I think is important. Provide exercise and turnout on a daily basis. This is important, I think. Whilst unproven, but actually there are some studies that look at fecal output of horses that are turned out versus stabled. Horses will definitely produce more manure when they have turnout. Provide clean, fresh water at all times. That's obvious. Placing feed on the ground, especially in dirt and sand floors, you want to avoid that, especially in sand. Having said that, hay nets also have their own problems. There's an increase in inhalable particulate matter from hay nets, and that can actually set off other problems like lower airway inflammatory disease. Check hay and bedding and pasture for any sort of environmental toxic substance or molds or fungus. That's obvious. And then stress reduction. This can be extremely individual to a horse. What you think should be a stressless environment for the horse could actually be the polar opposite thing for that horse. Some horses actually prefer being in a stall because that's what they're used to. If you suddenly turn it out all day, that could be the stress event for them too. Anytime they're stressed, the sympathetic nervous system goes up. They can have ileus, they can gas up, they can flip their colon. I think stress reduction is extremely important. Things not to do if your horse has colic: watch and see if it gets better on its own. I think that is, it's folly if you think so. Attempt any invasive procedure by yourself. Redose any analgesic medication over and over. So 1 dose of Banamine, okay, especially if you've spoken to your veterinarian, they're on their way, you need to do something. But if it hasn't worked in 20 minutes, redosing Banamine, it is labeled for twice a day at full dose rate maximum. Whoops. Was I kicked off?
Nope, it still should be good.
All right.
We're down to about 6 minutes, so
all right. I'm almost.
I don't know what will happen after the 6 minutes. Maybe we'll stop recording, or maybe we'll all see each other later. I'm not sure.
Okay, I'm almost done. I think it's like the second to last slide or something. Okay. Redosing analgesics isn't going to help you. In fact, you are going to actually run into more problems with that, like ulcer development, renal compromise, those sorts of things. Don't allow an actively painful horse to continue to eat, even if it wants to. If you have an impaction, which is often a spasmodic, episodic type of colic where they're not constantly in pain, they have pain when a wave of peristalsis or a wave of contraction goes over that impaction, and then they're normal. Otherwise, what you don't want to do is keep contributing to the obstruction until it's been evaluated. Give acepromazine. There is zero analgesic benefit from acepromazine. It is a tranquilizer. It is not a sedative. It has no analgesia. And in panic is never a good thing. So with that, I know it was a whirlwind trip through, and I'd be happy to answer any questions.
Yes, I have quite a few questions here in the queue, so I'll just go down the list and we'll get through as many as we can until we end. First question is from Vanessa. She says, what type of hay is best to feed to prevent impaction? Does feeding coastal Bermuda grass hay increase the risk of impaction? Why?
It does. I fortunately up here in New York don't see this at all. But my colleagues at Georgia, I was just speaking at the Focus on Colic in Lexington, and two of my colleagues are from University of Georgia. They will swear till you're blue in the face that coastal Bermuda hay is absolutely it's an independent risk factor for impaction colic. Specifically small intestinal impactions, which are actually pretty uncommon. We're talking about the differences between my population here and their population there. If a small intestine case comes into the hospital here, it's almost always a strangulation. The small intestine goes into the hospital down there. It is almost always an ileal impaction, and those horses rarely need surgery. They need fluids and decompression. Part of it is I think the lignified nature of the structure of the hay itself. I don't know whether it's highly associated with large colon impaction per se, but definitely small intestine for sure.
Okay. Does feeding extra salt help increase water and prevent impaction? There's a lot of different types of salt: table, stock, mineralized, Himalayan. What are a lot of different methods to feed it? Blocks, ropes, free choice, or top dress over feed? What is the ideal way to feed it?
That is opinion based for sure. The reality is that blood volume relates to sodium concentration in the blood, and obviously the higher sodium concentration in the blood, it's more tonic. It causes a stimulation of thirst. So yes, hypertonic blood by way of either intravenous injection of hypertonic saline or by ingestion of salt will increase the desire for thirst. Having said that, when you give it enterally, the kidney is extremely smart. It's much smarter than you and I, and its ability to excrete that excessive load of sodium is extremely high. So the benefit that you might perceive you're getting is actually probably getting counteracted by the fact the kidney says, you know what, no, I've got plenty of sodium in my blood already. I'm going to excrete it before I'm stimulating too much of thirst. Having said that, I still recommend it, especially for us up here as we start to get colder. I recommend top dressing light salt, so potassium chloride, because it's more appropriate from a physiologic standpoint, as it's osmotically active. It will kind of drag water with it because it's osmotic. So I use this light salt. I recommend that I have a salt block or a mineral block in the stall with the horse and in the feed tub, especially if you've got a horse that wolfs its food down. I think it's a really good obstacle for them to eat around. But then I also recommend a tablespoon or two at each grain feeding of light salt, so that's potassium chloride, that you can just top dress onto the grain. It's really opinion based, honestly. I don't think there's anyone that's worked out what's perfect, because I think it's going to be so individual to climate, humidity, and all those sorts of things.
Okay, so unfortunately we're down to the last few seconds here. So if we get cut off, I apologize. And ask you guys that have questions, please send them to fauna@fauna.com, and we'll forward them on to Dr. Hurcombe. Thank you all so much, and thank you to Dr. Hurcombe tonight for being with us. I think we all learned a great deal, especially on the surgical portion of things tonight. And so hopefully it was beneficial to you. I know that there was a lot of questions, so Dr. Hurcombe has maybe discussed doing kind of a roundtable or something like that to follow up on all this Q&A. That maybe we'll have a colic question and answer session. So again, if you have those additional questions, please send them over and we'll get them forwarded to you. Dr. Hurcombe. So once again, we thank everybody for taking the time out of your evening to be with us. And thank you to the Fauna Health and Education Committee for putting this together. We really look forward to the next Fauna Educational Webinar, and we will see you guys soon. Good night.
Thanks, Andy.